The National Institute of Allergy and Infectious Diseases defines asthma as a chronic lung disease that intermittently inflames and narrows the airways. According to the World Health Organization, asthma affects 235 million people worldwide.
Asthma is a respiratory condition that prevents normal airflow from outside to the alveoli of the lungs. During normal respiration, when we inhale, air goes in through the nose to the upper airways. Then it moves through the trachea or windpipe. The trachea branches into two large tubes called bronchi. Then inside the lungs, bronchi branch into smaller air pipes called bronchioli. Finally, from bronchioli, air moves inside tiny air sacs called alveoli, so that gas exchange can take place. Oxygen moves inside the blood, while some carbon dioxide diffuses in the opposite direction from the blood into the alveoli. In people with asthma, a flow of air is restricted due to narrowing of bronchi and bronchioles. Bronchospasm due to asthma is caused by three factors: constriction of smooth muscles around bronchi and bronchioles, swelling of cells in airways due to chronic inflammation, production of extra mucus due to inflammation and asthma triggers. These three factors cause the airways of asthmatics to narrow and swell. To some degrees, these factors can be present in people with asthma all the time. During an asthma attack, the degree of bronchoconstriction is even higher. As a result, asthmatics suffer from coughing, wheezing, whistling or rattling sounds in the chest tightness, and difficulty breathing. In people with asthma, the immune system is hypersensitive in relation to various triggers leading to an allergic reaction affecting the lining of the airways. Common asthma triggers include house dust mites, pollen, mold, cigarette smoke, proteins from animal fur or pet dander, pollution, cold weather, and cockroach droppings. However, there are many other factors that can trigger an asthma attack. These include lower respiratory infections, overeating, anxiety, psychological stress, exercise, and even laughter. As a result, during an asthma attack, a person breathes even heavier through already constricted airways. This further worsens existing inflammation, increases mucus production, and bronchoconstriction. All of these factors can make some airways nearly completely blocked or clogged up with mucus, triggering the urge to cough receptors and causing coughing. In such conditions, normal breathing becomes difficult or impossible due to asthma symptoms that can be mild, moderate, or severe and life-threatening, where immediate hospitalization treatment is required.
20 million people in the U.S. have asthma. It affects more women than men, more African Americans than any other group, and a higher percentage of children than adults. Of the 20 million with asthma, 9 million of them are children. They have smaller airways than adults, which makes asthma especially serious for them. 21.4% of African American children have asthma, but only 12% of white children do. Asthma affects a relatively low 7.9% of Hispanic children. But African American and Hispanic children visit emergency departments for asthma care up to 4.5 times more than white children.
Washington, D.C. is a real microcosm of pediatric asthma, and that the disparities present nationwide are very, very pronounced here in D.C. So we're looking due south from Children's National Medical Center towards the National Mall. The Capitol building is almost directly behind me. If you go more towards my right in that direction, look over RFK Stadium into southeast DC, you begin to enter neighborhoods with some of the highest rates of pediatric asthma morbidity in the nation. Within just a few miles of the White House, the Capitol building, you have rates of hospitalization among children for asthma that are dramatically higher than in the northwest part of the district, where rates are 1/10, 1/12, 1/15 of what they are in the more disadvantaged, principally minority parts of the district in the southeast and northeast.
For expert advice, we spoke to Dr. LaPera, a doctor of osteopathic medicine in the emergency department at Carilion Clinic.
Hi, I'm Allison Williams LaPera. I'm a doctor of osteopathic medicine from Virginia College of Osteopathic Medicine. I'm currently board certified in emergency medicine, completed an emergency medicine residency at Orlando Health, and now currently practice with a Carilion hospital system here in Virginia. We see asthma frequently in the emergency department, so I would say at least once a shift, if not every other shift. But it's a frequent complaint that we see. It really kind of spans the ages from young patients to older patients.
There are many different disease phenotypes that fall under the classification of asthma, and there is still limited understanding of the underlying mechanisms of the disease. As research on asthma continues, several studies have identified predictive biomarkers associated with asthma. These biomarkers will help us understand the biological mechanisms behind asthma and develop more effective methods for treatment and prevention.
Elevated levels of immunoglobulin E, IgE, a type of antibody released by immune cells that then triggers an allergic reaction. Depressed levels of EPO, a hormone involved in regulating red blood cell production in response to low blood oxygen levels. And increased glycoprotein 130, a cell membrane receptor associated with autoimmune and inflammatory responses.
So when we see somebody in the emergency department with asthma, it really depends on the severity of the asthma attack. So certainly our first step is to get them some bronchodilators, usually with albuterol, by a nebulizer that helps kind of open up their airway passages and allows them to breathe a little bit better. We start them on some steroid medication, either steroids through an IV or steroid pills by mouth. And then depending on the severity of the asthma attack, if they are in respiratory distress or kind of on the verge of stopping breathing, we have ways to either kind of put them on a ventilator or with some non-invasive positive pressure ventilation through a mask to help breathe and make sure that they're both oxygenating, and the real problem with asthma is being able to exhale and kind of get air out. So if we are discharging somebody from the emergency department after treating them for asthma, a lot of times we will discharge them with a short prescription for some steroid medication to kind of help them through the acute exacerbation. We will generally refer them back to either their pediatrician if they're a pediatric patient or their family practice doctor. If they had never seen a pulmonologist previously, either pediatric pulmonology or an adult pulmonologist, we may refer them that direction for pulmonary function testing. And the other piece of it is kind of prevention in terms of identifying kind of what triggers their asthma and minimizing that at home. And then the other part is controller medications, whether they need some daily controller medicines to prevent asthma exacerbations.
The American Academy of Allergy, Asthma, and Immunology provides a list of medications commonly prescribed and preferred for asthma treatment. Inhaled corticosteroids, inhalers, are the most consistently effective medication used for long-term control. Long-acting beta agonists are commonly used in combination with inhaled corticosteroids. Immunomodulators are medications that modify the allergic immune response to decrease sensitivity to potential triggers. These medications are taken daily. Short-acting beta agonists relax the airway muscles and are used for short-term treatment. This medication relieves symptoms but is not effective as a long-term management strategy.
So I'd say we see both young patients and older patients with asthma. I do feel that the patients that don't have primary care providers or are limited in their access to healthcare are less likely to be on controller medicines for their asthma, and more likely to be in an exacerbation or have more frequent exacerbations than folks that are generally well controlled on asthma controlling medicines. We also see some problems with smoking, particularly in like teenage and adult patients that have asthma and continue to smoke. That can be a real detriment to them and cause worsening asthma exacerbations.
Based on current evidence, parents, caretakers, healthcare providers, and public health advocates may consider taking the following measures to prevent childhood asthma. The most common trigger of asthma is tobacco smoke. Smokers can develop irreversible narrowing of the bronchial tubes from inflammation and scarring, causing permanent breathing problems. Secondhand smoke exposure in the home can contribute to a child developing asthma in the first place. The best way to prevent triggering asthma is quitting smoking altogether.
Childhood obesity is strongly linked to asthma. Maintain a healthy weight by eating a balanced diet and staying physically active.
Vaccinations help prevent viral infections, which often affect the lower respiratory tract and could trigger asthma attacks. Decreasing the frequency of lower respiratory tract infections in infancy reduces a child's risk of developing asthma.
Studies have produced conflicting results about an association between the duration and exclusiveness of breastfeeding and the development of childhood asthma. A population-based prospective cohort study conducted at the University Medical Center in Rotterdam, the Netherlands, and published in Pediatric Allergy and Immunology in 2016 showed that children breastfed for a shorter duration or less exclusively were significantly more likely to exhibit wheezing or asthma. A 2010 study by the University of Manchester published in Clinical Science found that breastfeeding for longer than 4 months had a protective effect against wheezing. Both of these studies associated the protective effect with a lower incidence of lower respiratory infections in exclusively breastfed infants. Regardless, breastfeeding has many non-asthma related benefits and is recommended when possible.
Indoor and outdoor allergens are common triggers of asthma attacks. Some outdoor allergens are pollen and mold. Indoor allergens come from dust mites, carpet, stuffed furniture, and pets. People who live in older or poorly maintained buildings may be exposed to more indoor allergens. According to the CDC, an air conditioner or dehumidifier can lower the humidity and prevent growth of mold.
Cities with more air pollution have higher rates of childhood asthma. Public health measures can focus on reducing air pollution to help lower the incidence of childhood asthma. If you live in a place with a lot of air pollution, the CDC recommends checking air quality forecasts and planning activities when air pollution levels will be low.
If you or your child has asthma, meet with a physician regularly to create a plan for managing asthma by identifying what triggers your asthma attacks, taking medication for asthma, and knowing how to treat an attack if it occurs.